Good afternoon, everyone. Looks like we've got a lot of folks on the line, so we'll go ahead and get started as soon as Sim says go.
I think we're ready, Dr. Vohra.
All right, great. I hope you can see my screen. We just have our medical providers update for today. And we'll just run through this agenda. There's actually not too much new stuff from last time, but just a few updates, and we should have plenty of time to have discussions and questions. So just by way of the agenda, we'll talk about COVID cases and hospitalizations, vaccinations, and some of the FDA language that came out related to myocarditis, pericarditis, and then some of the new rules, including a new AFL that might interest you if you work at the hospital or the skilled nursing facility level. And then some of the health officer orders that we've revised or are planning to publish soon. And then we'll just end with pain management resources and opioid use disorder updates. So in terms of our case rates and numbers, right now we're at 102,464 total cases. And as you can see from this slide, our case rate is hovering right around 2, which is pretty good. Now, this slide actually was contributed by Dr. Kokumar, our epidemiologist, and it actually compares Fresno, which is the blue line right here, with a few of our surrounding counties, including LA, Madera, Kings, and you can see that there are some concerning trends in some of the other counties. And that's because the other counties, including Kings and Madera, already have higher case rates than we do. And LA, most concerningly, is showing kind of an uptick right here, where they went from, around 1.5 to almost 2. And they keep on going up in terms of their case rate. Now, these are very small, subtle changes, and that yellow box represents the fact that a lot of this case information from the last couple of weeks is very fresh. It may not be complete. However, in the interest of developing a robust early warning system, this has raised some red flags. And actually, combined with the case rate increase, along with the detection of an increased number of Delta variant cases, LA actually went ahead and took the somewhat controversial step to recommend people get their masks back on, regardless of their vaccination status. So let me read to you, and I've actually added a link to their actual press release. And they basically just said, with the increased circulation of the highly transmissible Delta variant, the Public Health Department in LA strongly recommends everyone, regardless of vaccination status, wear masks indoors. And that's because Delta variants comprise nearly half of all variants sequenced in LA County. And they've said that basically that the Delta variants are now responsible for 1 in every 5 new infections across the country, which is higher than what it was before. It went from 10% to 20%. So from 1 in every 10 to 1 in every 5. So basically, they didn't wait for the state. LA County is itself bigger than 41 states in the US. I don't know if you knew that. So it basically acts like its own kind of city state. And it has a lot of pull whenever it makes these sorts of recommendations and pronouncements. So we are watching this very carefully. We've already fielded questions. I'm sure you have also about what we are going to recommend or require around masking. And honestly, I have mixed feelings because on the one hand, we do want to protect people from the Delta variant. On the other hand, we don't have that smoking gun here that we can say, okay, Delta or case rates are going up in our county to the point where we need to make some kind of a pivot related to the layers of protection that we're recommending. And on the third hand, at some level, this might disincentivize getting vaccinated. If you make people mask up regardless of their vaccination status, then the people that are still thinking about getting vaccinated are going to use that as an excuse not to get vaccinated because they don't have any incentive or reward to get vaccinated. That's more external. So that's why this is controversial. That's why we're really trying to look at all angles of this and really ask, what are the secondary and tertiary effects of reintroducing a harder guideline on masking or a more restrictive guideline on masking in general, we like to go along with what our neighboring counties are doing and saying and what the state is doing and saying, because I think it leads to less confusion in the general public. But this is where we are right now. This Delta variant is causing a lot of chaos at hopefully the denouement of this pandemic. And we're just watching day by day exactly what the data is telling us. Right now, LA is making this recommendation. We haven't heard anything from Sacramento, and we're kind of stuck in the middle, still watching the numbers. I don't know if Dr. K is on or if anyone else has any comments or questions about this very fast moving, rather subtle epidemiological development. In terms of the Delta variant, just, like I discussed last week, it has been proven to have increased transmissibility. It's been suggested from research abroad that it has increased severity in terms of landing people in the hospital and making people seek emergency care. And for what it's worth, the vaccines, at least the mRNA vaccines, seem to work against it. And so we're still just trying to push the vaccines as a way to protect ourselves and our communities against the Delta variant. And we just hope people get that message and really listen. We can talk about masks all day long, but we really need to spend as much resource and energy as we can getting people vaccinated and really trying to convince the skeptics to go ahead and get vaccinated using whatever tools we have at our disposal. Any questions about that or any commentary? Okay, I'll move forward just to talk about myocarditis. So, the FDA has now put in warning language or asked the pharmaceutical companies to put in warning language about the small but definite chance of myocarditis, pericarditis in patients who receive the mRNA vaccines, meaning the Pfizer and the Moderna products. This is still seen to be much less than the chance of complications related to COVID itself. So while it does represent what people are calling a legitimate signal in some of the adverse effects reporting databases that have been put into place, the risk of COVID is so great, and the risk of hospitalization from COVID is so great, even among young people who are otherwise healthy, that it makes sense to still recommend the vaccination, despite this very small higher chance of getting pericarditis, myocarditis. And remember that when you look at the studies that have documented this, they were doing some really interesting diagnostic testing. Like they were getting cardiac MRIs and cardiac CT scans, things that we usually don't do to work up myocarditis, pericarditis, at least in my experience. Obviously if a person comes in florid congestive heart failure, that's a much different clinical presentation and outcome than someone who just happens to have a diagnostic test that's positive, but they feel just fine. And so we have to keep in mind that, the clinical risk is rather low, even if people have either laboratory or imaging evidence of this cardiac inflammation. And it makes sense why they would have it. Basically, the vaccines are triggering an immune response, and the immune response leads to increased inflammation, which can attack different organs, including the heart. So it's not surprising that you find these kind of inflammatory changes after vaccinations. We just want people to interpret that in context, and people need to know that, unless they're actually feeling, some kind of a chest pain, shortness of breath, et cetera, they don't necessarily need to get checked out for this. But if people do come in with that kind of story, then their clinicians should be aware that, myocarditis, pericarditis is on the differential, and they should be comfortable working that up. And I added some more language about how to do that. The CDC actually has very good recommendations about the kinds of testing that needs to be done. Like, for example, EKG, troponin, inflammatory markers, CRP, ESR, and an echocardiogram as necessary, and also ruling out other causes, knowing that other kinds of viruses, other kinds of inflammatory and rheumatological conditions can also cause the same kind of presentation. Okay, in terms of new and changing regulations and rules, let me point you to the OSHA the OSHA website, which actually has some really good webinars coming up. In fact, there's one coming up tomorrow about the emergency temporary standards. So this is basically where OSHA explains the rules and expectations and roles of employers, just general employers, not necessarily healthcare employers, around COVID-19. And they basically are archiving these. You could probably find some of the older ones that have already passed online. But if you are in a position where you're overseeing HR, et cetera, then I urge you to sign up for these webinars, because you can hear from OSHA directly about what the roles and expectations are. And I think that they will do a good job covering all of those issues. In terms of healthcare providers, really nothing has changed in terms of the expectations related to PPE, related to barriers between workers and spacing, either in patient care areas or even waiting room areas, et cetera. None of that has really changed for healthcare. The only thing that's come out that may apply to your role as healthcare leadership is an AFL, and sorry to scroll up, but I'll scroll up to the AFL that I'm talking about. And this AFL just came out. It went live, I think, June 28th. And it basically has updates on quarantine and testing guidance for workers in hospitals, as well as skilled nursing facilities, and also the residents of health congregate settings, meaning skilled nursing facilities. And basically what this AFL is saying is that, if you have healthcare workers who are fully vaccinated, they no longer need to pursue a program of exclusion if they are a close contact. They can actually keep working. If they are at higher risk, either because of an immunocompromised condition or they're not fully vaccinated, then they can actually come back to work if they're asymptomatic on day 10, or they can come back to work on day 7 if they test negative on day 5. So I know that's a lot of information. Hopefully you can click on this link right here, item 4A, whenever we send out these notes, and read it for yourself. It's a pretty short memo, but it makes a lot of sense. And it basically just divides people into whether they're vaccinated or not, and then treats unvaccinated people as higher risk. And you should really communicate that with your staff and really urge them to get their vaccinations, because whenever they are not fully vaccinated, they are at risk to themselves as well as to patients and families and the rest of the community. And they really need to know that they will be held to a different standard, so that you don't have confusion or frustrations whenever you treat people differently based on their vaccination status. That's exactly what's expected according to this AFL. And you should share that with your staff beforehand so they understand what the roles and expectations will be. In terms of other orders, so we've actually published our revised health officer order. It should be online, and Sim can drop that in the chat. We're getting ready to publish another order related to testing, which basically softens the requirement into a recommendation to offer testing if you are a clinician or a primary care provider. And then we're also working on changing a testing order related to schools, which may not apply to you or may not affect your practice as much, but we do have a separate order related to school surveillance, and we are changing that as well, and that's pending finalization. Dr. Linscheid has put together an amazing health alert related to pregnancy. So it's actually not an advisory, it's an alert, but that's a subtle difference. But basically, she's covering many different issues related to pregnant women. So if you see pregnant women in your practice, please take the time to read through this. It's super important because it has up-to-date information about how to deal with substance use disorder, how to offer opioid use disorder treatment for pregnant women, which is super easy to do and super important to do. How to screen for sexually transmitted infections such as gonorrhea, chlamydia, and syphilis, and how to talk to your pregnant patients about COVID-19 vaccinations, which again is very highly recommended. So it's going to arm you with a lot of good information if you treat pregnant women. Please look through that health alert, which is ready and should be pushed out hopefully soon, either this afternoon or later this week. And then we're also working on an advisory for osteoporosis prevention, detection, and treatment. So we'll be announcing the status of that as it becomes more finalized. Lastly, there's a lot of movement in terms of opioid use disorder and pain disorder. So just to give everybody a backstory, if you haven't been aware, we had a major chain of pain clinics which were closed down almost about a month ago now. These were the LAGS medical centers, and they treated thousands of different patients that had various different chronic pain disorders. And because they were abruptly shut down because of a state investigation, that really left a lot of patients in the lurch. And a lot of these patients are unfortunately left without primary care or good planning in terms of their pain management. And they're coming into urgent care, emergency care. I'm sure they're making their way to primary care practices, asking for help. And you may or may not feel comfortable with exactly the kinds of needs that they have. And in response to that, the state is really trying to make up for this development. And they've actually sponsored a lot of health advisories and webinars. And some of the health advisories and webinars are now archived. So I'll actually share those with you. There's actually a San Francisco-based group. I think they're located, in the San Francisco Department of Public Health. And they're called CIAO, which is, I forgot what it stands for, but they basically put on an webinar last week, and they've now got it archived on YouTube. So I just linked to it, and they also have the slides from that. And these are basically pain specialists. They do this all the time, and they're basically doing a lot of good teaching about how to manage and steward opioid use, and then identify people that may be struggling with opioid addiction and opioid use disorder, and how to get those folks into recovery or treatment. And really just at all aspects of the opioid use spectrum, either before somebody has a problem, while they're on opioids, or after they've managed to unfortunately develop opioid use disorder. There are different treatment strategies that can help all of those different kinds of patients. And within the course of an hour, they've really done a nice job just detailing all of those different types of patients. And they also offer one-to-one counseling. So I went ahead and registered to get my one-to-one counseling session with this group called CIAO, and I'll be doing that on Friday. And I'll send out a link whenever we send out these notes, because if you are seeing patients that are in a lot of pain or have complex pain needs, they will actually sit with you and coach you about the different strategies that are available. So I'm very curious to see exactly how that works, and I'm always trying to learn more about pain management myself. So I went ahead and registered for this one-to-one counseling session, and I urge you to do the same through this group called CIAO. And again, this is definitely targeted to clinicians that are dealing with patients, but may not feel like they're experts in pain management. So they are trying to help you navigate through this difficult time, knowing that the LAGS pain clinics have closed. And we've got lots of other links and websites. We've created advisories ourselves. Here's a bunch of other older webinars from this group called CIAO, and the Bridge program based in Oakland has a lot of different protocols that you can use for patients that are struggling with opioid use disorder. And you can really help yourself and your patients a lot by getting your X waiver. So I'm just putting in my weekly plug to get your X waiver, and I'll keep harassing all of you until you get it. So please go ahead and get your X waiver. It only takes 5 minutes. And I think that's all of the comments that I have. Let me take a little break and check the chat. Otherwise, if you have any questions or comments, you can go ahead and unmute yourself now. Thank you so much.
Hi, Dr. Vohra.
Hi.
Hi, this is Julie with Fresno Surgical Hospital. I have a couple of questions for you.
Yes.
So I attended that OSHA seminar yesterday and still have some confusion regarding healthcare workers. So I know that you said that there's been no changes made to healthcare workers, but we've been addressed by our surgeons. They're saying that some of the patients at other hospitals are not being required to wear masks if they're able to show proof of vaccination status. And are you suggesting that regardless of vaccination status, that we continue to have our patients and healthcare workers wear masks?
Yeah, I've never heard of that within a healthcare setting. I've never heard of anyone asking for vaccination status from patients or visitors, and using that as a license to not wear a mask. So that's totally, I would like to see that in writing if you're seeing that in other hospitals, or offline share which facilities are doing that, and we can ask them where they got that information.
Perfect. And then my other question is regarding the emergency temporary standard COVID-19 plan and the mini respiratory plan that we have to have written for OSHA. It requires that you do a job hazard analysis or risk assessment. And there is a COVID-19 healthcare worksite checklist and employee job hazard analysis that's been developed by OSHA. And when you're going through it, it actually says on here that if you are exempt from following this plan if you're a vaccinated worker and you're in a location either within the hospital or separate from the hospital that does not have direct patient care.
Mm-hmm.
So basically saying that it says that it exempts fully vaccinated workers from physical distancing and barrier requirements within well-defined areas of the workplace where there's no reasonable expectation
Right.
that any person is suspected. Okay, so in reference to that, that's saying in the risk assessment, basically that fully vaccinated workers, if they're not in direct patient care, do not have to adhere to the ETS standard or to the emergency standards.
Right. They're saying if two or several fully vaccinated employees want to have a meeting somewhere and they're not around patients, that they don't need to adhere to the social distancing and the masking standard.
And that's okay.
Yes, that's my understanding.
And that's okay for like locations off, even like off the hospital campus, like people who share an office and they're all vaccinated. We can allow for that.
Yeah, that's my understanding. Mm-hmm.
Okay. Thank you.
Sure. Yeah. Great question. Thank you. Any other questions? I'm just going to go through the chat. I'll go backwards just for entertainment. So Dr. Mitchell is chiming in and saying that MAT is going to be used in the incarcerated and prison population, the statewide, which is fantastic. So that is so great. That's definitely needed. There's just so much, there's so many lectures you could give just about the need for sensible drug policy in our incarcerated populations. So it's so great to hear from Dr. Mitchell that California at least is leading the way in offering medication-assisted treatment, which is the best and most humane way to treat patients that have substance use disorder in all of its institutions. And then that critical follow-up, which is when people are released from the institutions, how are they going to continue on their recovery and getting them plugged into different clinics. That's key. And I know that Dr. Mitchell and Dr. Zweifler are both passionate about that piece of it. So there are programs that we are trying to get launched in collaboration with behavioral health and with our jail system to make sure that happens. Again, there's a lot of help available, and it's just a matter of finding the resources. But you shouldn't think in this day and age that there's no help available for substance use disorders. I mean, I like to jest that there's been no better time in American history to be hooked on drugs. Now, I'm just saying that because there's so many resources available that it's really fantastic. You do have to kind of know the landscape a little bit, and that's some homework that we have to do at the level of public health and behavior health, is to really publicize and socialize all of the resources that are available. But there's so many different agencies and organizations that are working on this. And at the federal level, the Biden administration is making strides to try to make it easier and easier for people to access medications for addiction. So it's really it's a positive momentum that we really want to capitalize on. All right, Sim dropped the links to the different health officer orders, just in case you are wanting to see those. And then people are asking about the rates of hospitalizations with regard to the variants. Yeah, that's a good question. Off the top of my head, I don't know exactly, what of all the hospitalized patients that we have, and I don't know if I shared that, currently there's 62 hospitalized patients in our county. So out of those 62 patients, which ones of them have variants? That's a real gap in our epidemiological surveillance. It's something that we're hoping to overcome just with better communication. but it's hard because the strain testing takes so long that the patient may be gone by the time the strain results come back. And so we're always trying to play catch up. And we need to do better about communicating that piece to ourselves and to the general public. So thank you for reminding. I don't have any information about hospitalization and variants at this time. We did have one person. I don't want to break confidentiality here, but one of our recent fatalities, because we track COVID fatalities, obviously, was actually a person who was vaccinated. I don't know their variant status, but obviously a person who is vaccinated who goes on to die is very concerning. So this is going to get elevated to the state level. But it turns out that this person had multiple comorbidities, including renal transplantation. And renal transplantation, as you are all aware, requires lifelong immunosuppression. So what we think happened, we haven't been able to talk to the doctors directly, but what we think happened was this was a person who probably didn't get the benefit of vaccination because of their immunocompromised status. And that has been shown over and over. There's actually a couple of New England Journal studies that have documented this. Our own Dr. Dingra, who's a nephrologist and local leader here in Fresno, is actually working on a manuscript with some of his colleagues about this very issue and about the fact that renal transplant patients tend to have less immunogenicity in terms of their antibody levels to vaccines. And so there really is kind of a soft recommendation and not a very vocal one, but perhaps it needs to be more vocal, that these people might need a third shot. They might need a third booster just to get their immune level up, because it seems like the 2-dose regimen is not really doing, what it does in normal people, which is afford enough protection to keep them out of the hospital. So that's an unfortunate case that, like I said, I don't want to overshare because I don't have a lot of details, but it seems like this is an example where, patients that are immunocompromised for whatever reason, including renal transplant patients, seem to not get the same benefit from vaccines. They don't get the same protection from vaccines. So if you're treating patients that have lifelong immunosuppressive regimens, think about that and reach out to us. We can help you do antibody testing, and we can actually push to get them extra booster shots, as it were, because it seems like that's what's going to be needed. Like I said, I haven't seen any national hard recommendations about this, but when you read the literature about it, it's pretty evident that 2 shots are not enough in some patients. And this seems to be a subset of patients that might require 3 shots or more, just depending on what their antibody levels are doing. And I don't know if Dr. Dingra is on. We're going to invite him to do some media briefings with us about these findings. Like I said, he's working on a manuscript. It looks amazing, and with his permission, I might share it next week when we meet again. Again, the physiology makes sense, and unfortunately, it did lead to a death here in Fresno County in a patient that had renal transplantation. After
so this is Enrique, one of the Dr. Dingra's nurse. Any message you want me to relay to him?
Oh, yeah, no, that's fine. I've been texting him all day, and what I can do is see if he can join us in a future session. I don't know if you're aware of this project, but it's a really robust study where they looked at multiple different, dozens of different patients that had gotten the vaccine, and then they actually looked at antibody levels in them, not only once, but several times over 90 days. And they were able to very, very nicely show that the antibody levels are pretty good in the first month, but then by day 90, the antibody levels just go down and down. And by day 90, they have very little protection.
Okay.
Yeah, thank you, Enrique.
You're welcome.
Any other questions? This is a great discussion. Thank you all. Anything from, I don't know if Dr. Lindscheit or Dr. Zweifler is on. Sounds like a no. Okay, so we will I think we can go ahead and conclude. Just coming up, like I said, we have these different advisories that we are pushing out. If there's something you want us to work on or that you want to collaborate on together, please reach out to us like Dr. Dingra did. Dr. Dingra is really passionate about taking the best care of renal patients that he can. And he reached out to us because he wanted to elevate this issue. And so that's kind of how we germinated the messaging around this project. But I know all of you are working very hard for your patients as well. So if there's something else that you need our help with, please let us know. We're always trying to be as agile as possible and as responsive as possible to our medical community. We know that it's not all about COVID, and we hope that that message comes through whenever we talk about non-COVID issues on this forum. But we need to be doing more, and we need to be teaching each other about what we need to focus on. So please keep that in mind. If you have other projects or just suggestions that you want us to be working on, then please reach out to us. And somebody's asking about the best contact info. And I would say if you email Sim, Sim does a fantastic job with relaying the request to myself or Dr. Zweifler, Dr. Linscheid, Dr. Mitchell, many of the other doctors that we're working with, or other teams that we have here at Public Health. So I would say just use the same email that you're using to get onto this Zoom, and then reach back out to us with any suggestions or questions that you have. That seems to be working pretty well. And Sim's email is right there. And that's all I have. Please stay cool. We'll actually be talking about climate a lot this summer. I'm very scared and also very excited that we have so much momentum related to climate and health effects of climate science. And so stay cool and have a great 4th of July. And we'll see you after the holiday break and continue the discussion after that. Thank you. Take care. Happy 4th of July.